Hello friends, so today we are going to discuss one of the most analytical and logical concepts of upper limb orthopedics and peripheral nerve injuries, and that is the concept of ulnar claw hand and ulnar nerve palsy. Okay, so what our plan for today is we are going to discuss the ulnar nerve course and anatomy in detail. We are going to discuss the Etio pathogenesis of ulnar claw hand. We are going to discuss the salient features of presentation of how ulnar claw hand presents to the OPD room. We are going to discuss in detail the very interesting concept of the ulnar paradox. We are going to discuss low vis-a-vis high vis-a-vis combined ulnar claw hand, ulnar nerve palsy. Okay, and we are going to discuss the partial versus total claw hand concept. We are going to discuss the very interesting concept of assisted angle. Okay, and at the end, we are going to discuss the management of a case of ulnar claw hand, including the static and dynamic procedures, along with the interesting tendon transfers. Okay, so without further ado, let us begin with the anatomy. Let us begin with the basic anatomy of ulnar nerve. Okay. So as we all know, where does ulnar nerve arise? It arises from the medial cord of brachial plexus. So what is the nerve root value? It is C8T1. Okay. Moving distally, it runs medial to the brachial artery and pierces the intermuscular septum, where it enters the posterior compartment of the arm. Okay, moving distally, it runs at the posteromedial border of humerus and passes behind the medial epicondyle at the elbow. That is the cubital tunnel. This is the common location where subluxation occurs, when anterior subluxation of the ulnar nerve occurs. Okay. Moving distally from elbow, it enters the anterior compartment of the forearm between the two heads of FCU. This is the place, one of the most common place of compressive neuropathy. Okay. And going distally at the wrist, it lies superficial to the flexor retinaculum and enters the palm via the Guyon's canal. Okay, so the important landmarks are first C8T1. It is the beginning. This is how ulnar nerve originates. Okay, it pierces the intermuscular septum. Okay, and then it passes behind the medial epicondyle of the elbow and comes to the anterior compartment of forearm between the two heads of FCU, and it lies at the wrist. It lies superficial to the flexor retinaculum. So these 2 to 3 points you need to keep in mind while discussing and understanding the anatomy of ulnar nerve. Okay, so what does ulnar nerve supply? This is very important. This part is extremely important to understand the mechanism and the biomechanics. How does biomechanically ulnar claw hand deformity occurs? Okay, so at the higher level, ulnar nerve supplies to the elbow joint. It supplies FCU. It supplies the medial half of FDP. Who supplies the lateral half of FDP? It is supplied by median nerve. Okay, so keep this in mind. At the higher level, it is supplying FCU. At the same time, it is supplying medial half of FDP. Okay, now at the lower level, it supplies the hypothenar intrinsic muscles, that is all the digiti minimi, flexor digiti minimi, abductor digiti minimi, and opponens digiti minimi. It supplies all the interossei. It supplies both palmar and dorsal interossei. Keep this in mind. Ulnar nerve supplies all the interossei. Okay. Then it supplies the third and fourth lumbricals. Now, which now supplies the first and second lumbricals? It is being supplied by the median nerve. Keep this in mind. First and second lumbrical by median nerve. Third and fourth lumbrical, that is medially, it is supplied by ulnar nerve. Additionally, it also supplies the muscle causing the key pinch, that is adductor pollicis. Okay, so very important muscle causing the key pinch of the thumb, which is supplied by the ulnar nerve, adductor pollicis and palmaris brevis. So most important, proximally at the higher level, it supplies the FCU, it supplies medial half of FDP, and distally it supplies all the interossei, third, fourth lumbricals, adductor pollicis, and the hypothenar intrinsic muscles. Am I making sense? Okay. And what is the sensory supply? The sensory supply of ulnar nerve is by palmar cutaneous branch and dorsal cutaneous branch. What does it supply? It supplies the medial 1/3 of the palm and medial 1 1/2 digits. Okay. Am I making sense? So this was the basic anatomy, and this is most important to understand the biomechanics, the deformity of ulnar clawing. Okay. So moving further, what are the common etiology? Okay, so most commonly the etiologies of ulnar claw hand. First is ulnar nerve involvement. So it could be post traumatic, it could be post operative, it could be compressive neuropathy. Okay, so what are the common sites where the ulnar nerve gets compressed? Imagine the previous slide. So most importantly, it gets compressed between two heads of FCU. Okay, it can also get compressed at the arcade of Struthers. It can get compressed at the medial intermuscular septum, and it can get compressed between the Osborne ligament and MCL ligament. Okay, so these are the common sites of compressive neuropathy. It could be some post-operative case, it could be some post-traumatic case. Okay. Then secondly, ulnar clawing could be due to some higher lesions, due to some lower brachial plexus lesion, that is lesion at C8 T1. So higher. Now what are the infective causes? The infective causes of clawing are commonly leprosy and polio. Okay. We'll discuss how the stigmata of leprosy in subsequent slides. Okay. Then some mechanical causes. So what are the mechanical causes? VIC and Dupuytren's contracture. These are the contractures which causes ulnar clawing, and some systemic disease like syringomyelia and Charcot-Marie-Tooth disease. These also cause ulnar clawing. Okay, so most importantly is because of the ulnar nerve involvement due to these compressive neuropathy. It could be some higher lesion because of lower brachial plexus lesion, and infective causes like leprosy and polio. Okay, so moving further, it could be the palsy could be either neuropraxia, it could be axonotmesis, or it could be neurotmesis. Okay, so what are the common conditions of neuropraxia? Like crutch palsy, tourniquet palsy, Saturday palsy. Common condition causing axonotmesis are closed fracture. Okay, neurotmesis could be some open injuries, or it could be chemical neurotmesis due to injection palsy. Okay, so this was the basic etiology of ulnar clawing or of ulnar nerve palsy. Now we are going to discuss the salient features, how a patient of ulnar claw hand presents to the OPD room. That is what we are going to discuss. Okay. So the basic crux, the basic pathology in ulnar clawing is hyperextension at MCP joint and flexion at IP joint. Am I making sense? Both are most important part deformities in ulnar clawing: hyperextension at MCP joint and flexion at IP joint. And what it is called? It is called Duchenne's sign. Okay, so Duchenne's sign is the most common presenting feature of ulnar clawing. Depending upon the level of lesion, depending upon of coexisting nerve injury, it could be partial clawing, it should be complete, it could be complete clawing. That depends on the level of lesion. Okay, so next salient feature is ulnar paradox, that we are going to discuss in detail. It is very lovely concept, we are going to discuss in subsequent slides. Okay, then there is a loss, as I said, there was a loss of function of adductor pollicis. So what happens is thumb adduction becomes weak or absent, and what does it lead to? It leads to the key pinch getting affected. The key pinch function of adductor pollicis gets affected. Okay. Additionally, the common things we see in peripheral nerve injuries is there are trophic changes in skin, hair, nail, and there might be some sweating. Okay. And muscle wasting characteristically is seen in the muscle supply by ulnar nerve, that is hypothenar muscles. Additionally, the introtia wasting also occurs, but the wasting of first dorsal introsia is marked, so it leads to showing of classical wasting in the first web space and hypothenar muscles. These spaces shows classical wasting in the case of ulnar claw hand. Okay, additionally some salient features. Okay, so whenever you tap along the course of the nerve, whenever the tingling is along the course of the nerve, it is called as the Tinel sign. As you all know, it indicates that the nerve is regenerating. Now, but if on tapping the tingling is locally at the site of tapping, it could be a neuroma. Okay, Now, the most common infective cause of ulnar claw hand was Hansen's disease. So, what are the common stigmata? What are the characteristic signs and findings in the case of Hansen's disease? There could be nerve thickening or neuritis. There could be nerve tenderness. There could be nerve abscess. One of the classical thing is subluxation of ulnar nerve at the medial condyle, glove and stocking type of pattern of sensation loss, and multiple hypopigmented patches. Usually the patient has a history of taking some drugs for skin condition. Okay. Additionally, what do? We look for some bony pathology, which might be a etiopathogenetic factor leading to ulnar claw hand. So there we look for non-union lateral condyle of humerus, we look for old malunions, we look for neglected dislocations, we look for cubital tunnel syndrome or Guyon's canal syndrome. Okay, cubital tunnel at the elbow and Guyon's canal at the wrist, as we already discussed in the anatomy. Okay, so these are some of the common etiopathogenetic factors which we should not miss as an orthopedic surgeon. Okay. Now what is the pattern of sensory loss? So in low palsy there is sensory loss at the medial 1.5 digits and medial 1/3 of the palm, and in high palsy additional along with this there might be the ulnar 1/3 aspect of the volar forearm. There is sensation loss in high ulnar nerve palsy. Okay, and what is the autonomous zone? Of ulnar nerve? It is the pulp of little finger. Okay, so these were the salient features how a presentation of ulnar claw hand occurs in the OPD room. Now we are going to understand the very logical and analytical concept of ulnar paradox. Okay, so now first we will understand the basics. Okay, so the function of flexion at MCP joint and extension at IP joint, it is done by two group of muscles. Most importantly, the lumbricals. Okay, first, second, third, and fourth, as you all know. And additionally, the same function is being performed by the introccei, both the palmar and dorsal introccei. Okay, so these are the secondary function of introccei, and lumbricals primary function is flexion at MCP joint and extension at IP joint. Okay, now the primary function of introccei is palmar introccei AD ducts and dorsal introccei AB ducts. That is, we know with the key mnemonic PAD and DAB. Palmar adduct, dorsal AB duct. Okay, that is the primary function of introccei. Okay, now the function of flexion at IP joint. The flexion at IP joint is by long flexors, is by the FDP. Okay, so now as we discussed in the anatomy slide, the medial half of FDP is supplied by ulnar nerve. There is hybrid supply, while the lateral half of FDP is supplied by median nerve. Remember this very important concept. Flexion at IP joint by long flexors, that is FDP, the medial half of which is supplied by ulnar nerve and lateral half is supplied by median nerve. Okay, am I making sense? Now the lumbricals which functions as flexion at the MCP joint and extension at IP joint. The first and second lumbricals are supplied by median nerve, and third and fourth lumbricals, that is over the medial aspect, it is supplied by the ulnar nerve. And all the introccei, palmar and dorsal, both are supplied by ulnar nerve. So we'll quickly revise. All the introccei by ulnar nerve, lumbricals first and second by median, third and fourth by ulnar nerves. Okay, and the long flexors which causes the flexion at the IP joint, that is FDP. The medial half is supplied by ulnar nerve and lateral half is supplied by median nerve. Okay, so remember this slide. This is very important to understand the further concept. Now we are going to understand what is a low ulnar nerve palsy, and then we are going to differentiate with high ulnar nerve palsy, and that is when I am going to tell you why do we call it as a ulnar paradox. Okay, so moving forward, in low ulnar nerve palsy, what happens is introccei are lost. Okay, third and fourth lumbricals are lost, and adductor pollicis are lost. Adductor pollicis function is lost. Okay, while what is intact? The FDP medial half, as there is low ulnar nerve palsy, the higher function, the higher supply, that is medial half of FDP, is intact by ulnar nerve, and lateral half is anyway intact by median nerve. Okay, so what is intact? FDP is intact. Additionally, the first and second lumbricals, which is supplied by median nerve, those are intact. I'll show you. If you want to see the slide of anatomy, I'll show you. Okay, so this was the higher supply. This was the higher supply of the ulnar nerve, which is spared in low ulnar nerve palsy. Okay, so medial half of FDP is spared, FCU is spared, but this part, the lower part, because it is a low ulnar nerve palsy, so interossei are gone. Interossei are gone, hypothenar muscles are gone, third and fourth lumbricals are gone, and adductor pollicis is gone. Okay, am I making sense? So that was the concept of low ulnar nerve palsy. Okay, so now due to loss of these functions, loss of these muscles, how does it affect? So what are the functions which are lost? The functions which are lost are, so due to interossei and third and fourth lumbricals, at the fourth and fifth finger, what happens is, at the fourth and fifth finger, the flexion at MCP and extension at IP joint is lost due to low ulnar nerve palsy, which is affecting the interossei and third and fourth lumbricals. Due to low ulnar nerve palsy, the interossei and third and fourth, due to low ulnar nerve palsy, the interossei, third, fourth lumbricals are lost. Due to low ulnar nerve palsy, the functions of interossei, the supply to interossei and third and fourth lumbricals is lost. So what is lost? The flexion at MCP and extension at IP joint for fourth and fifth finger is lost. Okay. Additionally, the adduction and abduction of the fingers is lost due to the loss of ulnar nerve supply to interossei. Additionally, what is lost? Thumb adduction, which was being caused by adductor pollicis, is lost. So what is lost? The key pinch is affected. Am I making sense? Okay, so the flexion at MCP and extension at IP joint for fourth and fifth finger is lost due to the loss of interossei and third and fourth lumbricals. Additionally, adduction, abduction of finger is lost, and thumb adduction is lost. Okay, but what is intact? It is a low ulnar nerve palsy. So the higher supply is intact. So what is intact? The flexion at IP joint by FDP is spared because medial half of FDP was supplied by ulnar nerve at a higher level, and lateral half is anyway supplied by median nerve, which is intact. Okay. And additionally, what else is intact? The median nerve is intact. So the first and second lumbricals are intact. The function of first and second lumbricals is intact. So flexion at MCP and extension at IP joint is normal for second and third fingers. So there is no clawing at the second and third finger. So that is what we are going to discuss. So in low ulnar nerve palsy, because of this reason, the third and fourth lumbricals are lost, interossei are lost, but long flexors, that is FDP, is intact. All this pathology occurs because of the third and fourth lumbricals. So clawing occurs at the fourth and fifth finger, but not at the second and third fingers. Am I making sense? Because first and second lumbricals are intact due to the median nerve supply. Okay. So that was the concept of low ulnar nerve palsy, in which you can see a partial clawing. That is, clawing is only at the fourth and fifth finger. Am I making sense? The second and third finger is showing no clawing. Okay. It is normal because the median nerve supply is normal. Okay, so moving forward, this was low ulnar nerve palsy. Now, what is the difference? In high ulnar nerve palsy? Okay, so in high ulnar nerve palsy, just imagine our slide of anatomy. Okay, what is lost? All the distal supply, the lower supply, that is interossei, is lost. Third and fourth lumbricals is lost. Additionally, at the higher level, the medial half of FDP supply is also gone, and adductor pollicis, the key pinch, is already gone at the lower level. Okay, so all these functions, all these muscles have lost their ulnar nerve supply. Now, what is intact? The median nerve is intact. Okay, so what is intact? What muscles are intact? So the first and second lumbricals are intact. and lateral half of FDP is intact. So grossly we can say that lateral half which is supplied by median nerve is intact, while medial half which is supplied by ulnar nerve, in medial half all the muscles are gone. Okay, so we'll discuss this concept. So whenever there is high ulnar nerve palsy, medially the third and fourth lumbricals are gone, introsea are gone, but at the same time the counteracting force which was causing the clawing at the fourth and fifth finger in low ulnar nerve palsy, the reason was the intact medial half of FDP which is lost in high ulnar nerve palsy. Am I making sense? Okay, so both the counteracting forces, this the left part which is causing the clawing, the right part which is causing the clawing, and the left part which was inhibiting clawing, both are gone, both are damaged. So both opposing surfaces are cut. So there is no clawing. Okay, there is no clawing. And on the lateral aspect which is supplied by the median nerve, first and second lumbricals are normal, are intact, because median nerve supply is normal. Additionally, the lateral half of FDP is also intact because median nerve is normal. Okay, so both the counteracting forces are intact and equal. So because of that reason, on lateral half there is no clawing. In medial half both are gone because higher lesion. Okay, FDP is not intact, so there is no clawing, while on the lateral half both are normal, so there is no clawing. So that is what is the concept of ulnar paradox. Because higher the lesion in the lower ulnar nerve palsy, what was the condition? There was clawing at the fourth and fifth finger. Partial claw hand was there in low ulnar nerve palsy. Claw hand was there, but in high ulnar nerve palsy there is no claw hand. The reason is very interesting, because on the lateral side the median nerve is intact, so both the counteracting forces are normal, while on the medial side both the counteracting forces have gone, so there is no clawing. So that is the concept of ulnar paradox, the very interesting concept, because higher the lesion, less is the clawing. Usually we feel that higher the lesion, the deformity should be more, but in cases of ulnar paradox, in case of ulnar nerve palsy, it is showing this kind of paradox. And lower the lesion, which increases the FDP, and FDS, which is spared, the long flexors are spared, which causes the IP flexion, which increases the clawing. Am I making sense? And most important part, we need to see the FCU, because it is the key muscle differentiating higher versus lower, because it is spared in the lower ulnar nerve palsy, as we can see in the anatomical diagram. Okay, so in low ulnar nerve palsy, I'll repeat, there is partial clawing at the fourth and fifth finger, while in high ulnar nerve palsy there is no clawing, giving the concept of paradox. Now you might ask me that we have seen cases of complete claw hand as well. So when does a complete claw hand occurs? The answer to that question lies in the subsequent slide. Okay, so whenever there is combined median and ulnar nerve palsy at the lower level, so what is lost? Because of ulnar nerve, all the introsea are gone. Because of the ulnar nerve, third and fourth lumbricals are gone. And because of the median nerve, the first and second lumbricals are gone. So all of these muscles have lost their functions. Okay, but what is intact? The long flexors, that is FDS and FDP, they are intact, spared, and they have the unopposed action, because all of them are lost. Okay, at the same time the long extensors are intact because of the radial nerve being intact. So there is unopposed MCP extension. So what happens is, there is unopposed MCP extension and unopposed IP joint flexion, which leads to and both the opposing forces and opposing forces at the medial and lateral, both the sides are lost, because there is combined ulnar and median nerve palsy. Okay, so that is the reason why in combined ulnar nerve palsy there is complete clawing. Am I making sense? Okay, however, in the cases of high combined ulnar and median nerve palsy, FDS and FDP would also be paralyzed with the paralysis of introsea and the lumbricals. So there would be markedly less clawing in high combined ulnar nerve palsy. But the common presentation of combined median plus ulnar nerve palsy is complete claw hand. Am I making sense? So quickly we'll revise in 10 seconds. Partial claw hand. When does it occur? In low ulnar nerve palsy. Why? Because the medial half of FDP is paired while lumbricals and introsea are gone. So that is the partial claw hand in the fourth and fifth finger. In high ulnar nerve palsy, there is no claw hand, there is no clawing. That is ulnar paradox, because higher the lesion, less is the deformity. Why? Because the medial half of FDP is also gone, while introsea and the lumbricals are gone. That is the condition over the medial side, while on the lateral side, both the lateral half of FDP and first and second lumbricals are intact because the median nerve is intact. So that was the high ulnar nerve palsy. While in combined median plus ulnar nerve palsy at the lower level, introsea and all the lumbricals are lost, while the long flexors and long extensors are intact, causing the complete clawing. Am I making sense? So that was the interesting concept. That was the logical and analytical concept of the difference between the higher versus lower, partial versus complete claw hand, and the ulnar paradox concept. Okay. So now similar to this, we have a very interesting concept of assisted angle. So this is a part of pre-op evaluations. There are 2-3 factors which helps us in deciding the management pre-operatively. Okay, so this is a very interesting concept. Let us discuss it. So as we discussed in ulnar nerve palsy, what happens is lumbricals, introsea are gone, FDP is intact. So due to all these conditions, there is hyperextension at MCP joint and flexion at IP joint. Am I making sense? The Duchenne's sign. Okay. So the fingers, now you understand this concept. Very interesting. Okay. So what happens is the finger are in extension. Okay. So due to the fingers being in extension at the MCP joint, the extensor can't act mechanically because they are loose. Can you imagine the mechanism, the hinge mechanics? Okay, so whenever the finger is more in extension, the extensors are not taut, so they can't exert the force biomechanically because they are loose. Now what happens is if you flex the MCP joint passively, what will happen is the extensors becomes taut. Okay, when you flex the finger, okay, what happens is the extensors become taut and they can exert the force biomechanically. So the extension at IP joint becomes possible. And IP joint is extended. So this interesting phenomena is known as Bouvier-Beaver phenomena. Okay. So let me explain you. If it is not clear to you, let me explain it to you again. Okay, so normally what is happening is there is hyperextension at the MCP joint in finger. Okay, at the MCP joint hyperextension is there, due to which the extensors are not able to exert the biomechanical force which can extend the IP joint. Am I making sense? So what do you do? You flex the MCP joint passively, which causes the extensor mechanism to become strong, which causes the extensors becoming taut. Okay, so that they can exert the force biomechanically, and extension at IP joint is possible. So that is why the IP joint becomes extended due to passive flexion at the MCP joint, which is known as the Bouvier-Beaver phenomena. Okay, am I making sense? So you need to imagine it logically. It is very interesting. Okay, so the angle at which the IP extension occurs due to passive flexion at MCP joint is the assisted angle. Okay, so I repeat, the angle at which, due to passive flexion at MCP joint, the extensor mechanism exerts the force at the IP joint, which causes the extension at IP joint. This is called the assisted angle. So what was the pathology in ulnar claw hand? There was hyperextension at MCP joint and there was flexion at IP joint. We need to counteract this. So whenever we flex the MCP joint, whenever we flex the MCP joint passively due to the extensor mechanism becoming taut, there occurs extension at IP joint. So both the forces are getting counteracted. So the angle at which the IP extension occurs due to the passive flexion at the MCP joint is known as the assisted angle. Now why it is so important? Because the management modality depends on the assisted angle. So whenever the assisted angle is less than 30 degrees, static procedures usually work, whenever the assisted angle is more than 30 degree, we need a dynamic tendon transfer. We are going to discuss the named procedures in the subsequent slides. Okay. Now the second pre-op evaluation is we need to see the contracture angle. So what was the pathology at the IP joint? So IP joint was flexed due to the ulnar nerve palsy. Now what do we check? Pre-operatively? We check whether we are able to passively extend the IP joint. So we passively attempt to extend the IP joint. But if the flexion at IP joint is fixed, if there is fixed flexion deformity, we check the angle. Which is known as the contracture angle. Why it is important? Because the contracture angle needs to be corrected prior to the tendon transfer. Why it is important? Because the contracture angle needs to be corrected prior to tendon transfer by splinting and physiotherapy. If we don't do that, even after a successful and meticulous tendon transfer, the surgery will fail because there is fixed deformity at the IP joint. Am I making sense? So these were two analytical pre-op evaluation which needs to be done prior to deciding the modality of management. Okay, so moving forward, some interesting and famous tests for the muscles which are supplied by ulnar nerve. Okay. So the famous card test, which we all know, we test the palmar interossei because it is testing the adduction pad, palmar adduction. So that is the card test, as we all know. Okay, now the second test for dorsal interossei. What is the function of dorsal interossei? DAB, abduction. Okay, so the classical test is the Igawa's test. Okay, so what do we do? With the hand on the table with MCP joint in slight flexion, the palm flat lying on the table? What do? We ask the patient to abduct. The middle finger medially and laterally to check for the abduction function, which is the Igawa's test, testing the function of dorsal interossei. Okay. Now the third test, very interesting and logical, the book test or the Froment sign. Okay, so the ulnar nerve supplies the adductor pollicis. Am I making sense? Which is important for the key pinch. As you can see over here, the key pinch by the thumb adduction. Now, whenever there is ulnar nerve palsy, what is weak? Adductor pollicis is weak. So the key pinch is affected. Now, how does our body compensate? The body compensates by using the FPL, which causes the flexion at the IP joint. Am I making sense? And how does the body use FPL? Because the median nerve is intact. So as a compensatory mechanism for the weak adductor pollicis due to the ulnar nerve palsy, what does our body do? To preserve the key pinch, flexes the IP joint by the FPL muscle due to intact median nerve. So whenever we see this kind of picture of flexion at IP joint, we say that it is a Froment sign positive and book test is positive for the ulnar nerve palsy. Okay, so these were the three important and famous tests which you should know and understand in detail. Okay. Now moving forward, we are going to understand the management of a case of ulnar claw hand. So what are the investigations? As we all know, we do X-ray to check for any fracture, dislocation, implant impingement, non-union, malunion, lateral condyle of humerus, all those things. We check for EMG, NCV, we check for USG. Usually, why do we check for USG? We check the nerve ends, neuroma, abscess, subluxation, scars, adhesions, all these in leprosy when we are suspecting a Hansen's disease. And additionally, important, we do skin biopsy when we are suspecting a picture of leprosy. Okay, so these are the basic investigations. So moving forward quickly, how do we manage a case of ulnar claw hand? Okay, so in neuropraxia and exonotomesis, what do? We usually go for a wait and watch approach. While in neurotomesis, we usually intervene. Okay, so how do we go for wait and watch? The conservative management is, for neuropraxia, we can wait and watch for 6 weeks, and exonotomesis based on the distance required to be covered. So 1 mm per day plus 1 month of Wallerian degeneration and regeneration. That is the usual protocol we follow for conservative management. What do we do in conservative management? We use the knuckle bender splint. At the same time, we advise the patient for physiotherapy, B12 supplementation, and electrical stimulation. Am I making sense? Now, whenever we are suspecting a neurotomesis, definitively we go for a primary epineural repair, that is neurography. And if at all there is more than 1 inch gap at the nerve ends, we need to go for a nerve grafting. Now the last part and very interesting part is the reconstruction procedures. When do we go for reconstruction? When there is no progress or recovery after 6 to 9 months of conservative management or wait and watch. Okay, so as we discussed, because of the deformity, what do we want to restore? We want to restore the flexion at MCP joint. We want to restore the extension and coordination at the IP joint, and we want to restore the key pinch because the adductor pollicis is affected. Okay. So the reconstruction procedures are broadly divided into static procedures and dynamic procedures. So when do we go for static procedures? We already discussed when the assisted angle is less than 30 degree. When do we go for dynamic procedure? When the assisted angle is more than 30 degree. What is the assisted angle? All of you should repeat along with me. What is assisted angle? Assisted angle is the amount of passive flexion at MCP joint which is required for the extension at IP joint. Okay, so if it is less than 30 degree, you go for static procedures. If it is more than 30 degree, you go for dynamic procedures. What is the concept of static procedures? In static procedures, what we do is we rearrange the existing forces. While in dynamic procedures, we carry out some tendon transfers. Okay, so very quickly we are going to name famous named procedures. Okay, so for static procedures, the commonly used and the famous procedures are Zancoli volar capsulorrhaphy. The most famous is the flexor pulley advancement procedure, which is the Binel Palende procedure. Okay, then the other procedures are Srinivasan extensor diversion grafting, ECRL tenodesis, and Mikhail bone block procedures. Okay, so these were the famous named procedures for static tendon transfers. Okay, so these were some of the named procedures for static reconstruction. Okay. Now for the dynamic procedures, when the assisted angle required is more than 30 degree, we go for tendon transfer. Okay, so what is the basic concept? The tendon passes deep to the transverse metacarpal ligament and inserts at the extensor expansion. Am I making sense? Okay, so the commonly performed tendon transfers are, for the dynamic procedures, the commonly performed are the sublimis transfer. What do we do? In that procedure, the FDS of middle finger is fashioned into slips and which is attached to the extensor expansion dorsolaterally. Am I making sense? That is the sublimis transfer. Now the second named famous procedure is the Zancoli lasso. What do we do in this procedure? The FDS of middle or ring finger is attached to all the fingers wherein the lasso is at the A2 pulley. Okay. Next is the Brand's procedure, in which extensor to flexor four-tailed procedural tendon transfer is done. So ECRL, ECRB tailed grafts are put to the at the A2 pulley. ECRL, ECRB tailed grafts are put at the A2 pulley. Am I making sense? And additionally in whenever there is total claw hand, along with other procedures we discussed, the opponent's plasty also has to be done. The EIP, extensor indicis proprius opponent's plasty, is already extensor indicis proprius opponent's plasty is also done along with the routine procedures, and the transfer should reach the APB from the ulnar side. Okay, so these were the reconstruction procedures, the famous named reconstruction procedures, which you need to memorize and understand. Okay, so this was all about the concept of ulnar claw hand, partial claw hand, total claw hand, ulnar paradox, assisted angle, contracture angle management, tendon transfers. This was all about the logical, analytical, and interesting concept of upper limb peripheral nerve injuries, and that is the idea. Of ulnar claw hand. I hope you found it useful. You can drop in your feedback in the comment section or in the social media page, which you can see on the screen. This was Dr. Mihir Tejura signing off with Ulnar Claw Hand simplified for you.